I'll be talking on endohepatology today, and for the fellows, the endohepatology should include a whole holistic view of how endoscopy is applied to hepatology, and this will include white light imaging. So with white light endoscopy, we will use magnification, narrow spectrum technology, digital enhanced endoscopy to define the endoscopic manifestations of portal hypertension. Endohepatology should also include biliary endoscopies, including the ERCP, cholangioscopy, intraductal ultrasound, and a whole vast area of US guided biliary drainage. Then there is a very big area of metabolic endoscopy, which applies to steatotic liver disease, including bariatric endoscopy. Then small bowel endoscopy, the small bowel features of portal hypertension, which will be studied with enteroscopy and capsule endoscopy. But in general, endohepatology has come to connotate endoscopic ultrasound as applied to liver. And in this talk, in the next 30 minutes or so, we will see how we use EUS to assess liver fibrosis invasively, non-invasively, how we use it to assess liver fat, how we use it to assess portal hypertension invasively and non-invasively, hemodynamic and vascular changes, endotherapy of varices, evaluation and treatment of HCC by US, and some miscellaneous causes. So before we begin, we should know the US anatomy of liver, and we were the first to describe this with a linear probe in 2013 and with a radial probe subsequently in 2019. So let us begin by assessment of liver fibrosis, and this is US guided liver biopsy. So for an adequate liver biopsy, we assess three parameters. One is the length of the biopsy, second is the width of the biopsy, and third also fragmentation. So some of these biopsies will have the similar length and width, but will be more fragmented. Now the first question is, what is an adequate liver biopsy? So this was a landmark paper by Guido Colorado, published in Journal of Hepatology 2003. And what these investigators did, they took 161 liver biopsies from the repertoire, each of which measured more than 3 centimeters in length, and then they evaluated them for the portal tract, grading and staging. And then they covered part of this liver biopsy with a black paper to effectively reduce their length, again repeated, and then covered it with again a black paper and again repeated. So in this slide, what you see on the y-axis is the complete portal tracts in the liver, and beyond the neutral line on the left, you have the histological activity index, and on the right, you have the fibrosis staging. So what this shows that as the number of CPTs in the liver biopsy go up, you less often understage the liver biopsy and undergrade the liver biopsy. So this told us that at a threshold of 11 CPTs or so, you will adequately grade and stage liver biopsy, and a larger biopsy or more CPTs will not give you incremental gains. Further on, these investigators showed that in a liver biopsy 2 centimeter long and 1.4 mm wide, this number of portal tracts, that is CPTs 11 to 14, were guaranteed in 94% of the time. So based on this, the adequacy criteria for liver biopsies were laid down, which I have mentioned here. The ASLD, the ESL, the APASL, the British Society of Gastroenterology, and the Royal College of Pathology. So you basically need a liver biopsy of more than 20 or more than 15 mm, and you need CPTs more than 10 or more than 11. And in general, if you are going to diagnose a diffuse liver disease, say steatosis or autoimmune hepatitis, you can get away with this criteria. But if you have to adequately stage and grade the fibrosis and inflammation in hepatitis B and C, then possibly you need a bigger biopsy of 20 millimeter and more than 11 CPTs. Now what about EUS liver biopsy? The first question is whether, it is adequate or not. So I have listed a huge number of studies here, and I have sort of summarized all of these studies, that the majority of these studies have shown that you do get adequate and diagnostic liver biopsy specimens when you use the US guided route. What about the comparison of US with percutaneous liver biopsies? There have been 5 recent studies, and these have been compiled in a meta-analysis, and they have said that, look, percutaneous liver biopsy gives you a better yield, longer specimens, more CPTs, even though US liver biopsies by themselves were adequate in the majority of cases. However, these studies had methodological flaws and some of them used actually fine needle aspiration and not biopsy needle. So the jury is still out as to if US liver biopsy can actually replace or is as good as percutaneous liver biopsy. Now, the patients which have been studied with US liver biopsies have mostly included those with coagulopathy, and INR more than 1.5 or platelet less than 50,000 have been excluded. There is minimal data on cirrhotic patients. There is no experience in decompensated cirrhosis, and the most common indications were transaminitis and fatty liver on imaging. The procedure cost, we use biopens here, and it is much cheaper than a 19G Francine, which is used in this department. So at ILBS, a percutaneous liver biopsy using a biopens will cost around 15,500 to 16,000 rupees. While when we do a US guided liver biopsy with a Francine needle, it will cost the patient around 44,000 rupees. So when we study our patients, a large majority of patients will deny US liver biopsy because of cost reason. And also, we were surprised to see, unlike what we believed, many patients considered US liver biopsy to be a more invasive option and not a more comfortable option for their liver biopsy. Now, this is how we do liver biopsy in the department. We set up a table like this, and we use a modified wet heparin technique in which we flush the needle with heparin, and then we apply suction, and we use this needle. This is now the best needle for liver biopsy. This is a 3-pronged Francine needle which has 3 prongs at 120 degree around symmetrical cutting edges, and then it is simple. You just apply suction and you move the needle 3 or more times in the liver. Mostly we puncture the left lobe from the stomach, and then we have got histology cassettes from the pathology. We use heparinized saline to flush, and then the blood doesn't clot and the core sort of stay on the histology cassette, and we can use a cotton tip swab or we just float it off the histology cassette into formalin. So for the pathologist, there is minimal blood in the specimen, and you have cores which can then be embedded and sectioned. Now the adverse events with percutaneous and US liver biopsies are practically equivalent. This is a landmark study by Meenak in gastroenterology 1987, in whom they randomized patients undergoing a percutaneous liver biopsy to 6 hours and 24 hours of bed rest with protocol ultrasound, and showed that the majority of adverse events occurred within 3 hours. So now the protocol is to rest these patients for 4 to 6 hours, and with US also we follow the same. A earlier discharge, to my mind, is not very wise. Pain has been described more often in percutaneous liver biopsies. In most of the US guided liver biopsies, pain has been very uncommon, except in the study by Nito et al., who have been very aggressive, in whom a large number of patients required analgesics. Now, the radiologists can actually use a coaxial introducer system through which they pass the biopsy needle, and they can plug their track after they do the liver biopsy. Now with US, we have no such recourse. This is one of my patients where after I was withdrawing the needle, a track of blood followed me, and then the only option I had was to hold the needle there and push the biopsy specimen back so that the track is plugged. If we withdraw the needle and the hematoma, subcapsular hematoma, starts accumulating, then with US, there is no correction for this complication. And complications do happen. This is another one of my patients who next day I found had a large hematoma and a hepatic laceration after a US guided liver biopsies. So even though we do not report in the literature much adverse events, they happen, and we must be cognizant of the fact. Now, we would obviously want to do less of liver biopsies and go for non-invasive assessment of liver fibrosis. And let me show you a couple of techniques which are now available. Much of these have been done by radiologists for a long time, but these are now available to us with US. Now this is a strain or a real-time elastography of the liver, where a ROI is placed in the liver, and this ROI tells you the relative strain of the tissues which are inside this ROI. Now the stress which is applied to the tissues in this modality, unlike shear wave elastography or fibroscan, is not known. So the color coding inside this ROI is the relative depiction of the strain. So this ROI is placed around 1 to 1.5 centimeter below the liver capsule, and by eyeballing you can have some idea of how the liver is. We can also have a strain ratio where we compare the fat in the gastric wall to a ROI in the representative ROI, representative area in the ROI. We can also use a strain histogram where if the pixels are more blue, then the histogram is actually the numerical value goes back down like this. So the advantage of this technique, strain elastography, is possibly that inflammation may not influence this much, and congestion and other factors where the VCTE or fibroscan actually may be inaccurate. This, since it gives you a relative stiffness in this ROI, may be more accurate. Now, very few studies have looked at this. This was a study by Robles, Miranda, Carlos, in whom his gold standards was the fibroscan here on the y-axis, and you had this strain ratio and strain histogram. Sorry, I don't have my spectacles, so I'm having difficulty in reading this. So you saw a lovely correlation between the liver stiffness as defined by the strain elastography and the strain histogram, both in the liver and in the spleen. Now, you must understand that since the ROI is not giving you an absolute value, as cirrhosis progresses, the fibrosis becomes more patchy. So in the ROI, the color dispersion increases. So now instead of a uniform green hue, now you have a patchy color in this ROI, and this has been quantified by Hitachi software into what is called a liver fibrosis index. Now LFI is a quantitative value, and this study by Schulman in 50 patients undergoing US with the Pentax system showed that the LFI score could beautifully discriminate cirrhosis from fatty liver from normal, and in practice we use a cutoff value of 2.56 to discriminate F4 fibrosis on US. And this is a very simple and non-invasive technique to define liver fibrosis when the fellows or we are doing a US study. This is just to show you some representative example. Eyeballing of the ROI, the strain histogram looks the same, but this is normal, this is fatty liver, no cirrhosis, and this is F4 on liver biopsy. Now the next technique, which many of us are more familiar, are RFI-based techniques, that is shear wave elastography. On EUS, we do not as yet have facility for 2D shear wave elastography, so what we have is point shear wave elastography. And this is how it works. This is the EUS, this is the transducer, this is the ROI where we interrogate. So RFI is basically a push pulse of ultrasound, and this is a special kind of ultrasound pulse which actually transfers its momentum where it is focused. So it sort of pushes the tissue. It is a kind of a stimulus which is given here in the center, and then because of interference and constructive summation and interference, you have shear waves which go perpendicular to the RFI. So it is like if you drop a stone in a pond, you have ripples going all around. So if you have a focus RFI here, shear waves go perpendicular, and then you have tracking waves which will tell you the velocity of the shear waves in this ROI, and the stiffer the tissue, the faster the shear waves will go, and then you can work backward with the velocity to calculate the elasticity modulus. So this is how you get a report. We normally take 10 readings, and you get a shear wave velocity, you get a calculated elasticity modulus, and you get something called VSN, which we will just tell you. So the current machines also give you quality parameters, and the most important of which is VSN, which is the number of push track sequences that have been successfully captured by the machine, and it tells you how reliable your point shear wave elastography calculation is. You also have IQRM standard, less than 30% for E and less than 15% for the velocity estimation with shear wave elastography. So these are very good non-invasive or minimally invasive techniques for estimation of liver fibrosis. Only one study, unfortunately, with US by Kohli et al. In 42 suspected NAFLD. They did a shear wave elastography using Olympus system and biopsy, and this is all the studies that we have. Now what about the cutoff values? Most of you would know the Baveno rule of 5, 10, 15, 20 using the vibration control transient elastography. But for the RFI based techniques, now RSNA has promoted the vendor neutral rule of 4, that is 5, 9, 13 and 17 kilopascal. And if the RFI based technique, the stiffness is less than 7, fibrosis is ruled out, and if it is more than 13 or 17, this patient has significant fibrosis or cirrhosis. So based on the incentive by Cuba, now most of the machines, most of the vendors now agree on these cutoffs. This month, there was a very interesting article on US guided liver palpation in GI endoscopy by Kenneth Chang's group. This was a very elegant concept that you just place the transducer over the liver and then you depress the transducer. And a stiffer liver will deform less, a softer liver will deform more. And they gave cutoff of 3.5 millimeter, which had 100% predictive value in ruling in advanced fibrosis. And if you could depress the liver more than 4 millimeter, it practically ruled out cirrhosis. So this is very simple. You can just keep the US transducer over the liver and measure how much you can depress, or it is a kind of a US guided palpation. And more the stiffer the liver, the less you can indent it. Something very elegant, sound speed estimation. This is actually the prototype from Fujifilm, and what they do is, it is based on the premise that the conventional ultrasound systems suppose that the speed of sound in all biological tissues is 1540 meter per second, and this value is used to convert the time to distance. However, in biological tissues, the propagation speed of ultrasound varies by around 150 meter per second or plus minus 10%. And this difference can be used to provide an acoustic impedance contrast. Now, what these machines or these processors do, they take data from a single IQ channel and then they create different images from different supposed sound speeds, and then they analyze these different images for the frequency spectrum and for the lateral resolution. And they choose which image has the highest lateral resolution, and that is the best sound speed. So, this study by Buzari et al. Showed that as the liver fibrosis increased, this was a transabdominal study, the sound speed also increased. And this is one of our patients where we have calculated the sound speed as 1620 meter per second in a patient who had advanced fibrosis. So just with a switch of a button, you can show that the sound speed varies with the degree of fibrosis and steatosis. The logic is that with increasing fibrosis, the speed of sound increases. With increasing fat content, the speed of sound decreases. In this study by Buzari, at this cutoff, cirrhosis could be diagnosed with a reasonable sensitivity and specificity. These two studies by Bergio and Popa, they used MRI proton density fat fraction to quantify steatosis and showed that at a reduced velocity cutoffs, you could diagnose steatosis or you could quantify steatosis very nicely, non-invasively. These are lovely techniques. Now, besides speed of sound, the assessment of liver fat is normally done by attenuation imaging. And this is how a fatty liver looks on B mode. It's a bright liver in the near field, and there is eco-extinction in the deeper fields because the fat reflects ultrasound, so it is bright, but there is also no increased attenuation of the ultrasound beam as you go to the depth. And B mode has a sensitivity to pick up a fatty liver once 20% of the hepatocytes are fat transformed. And we all know the controlled attenuation parameter. This is the most important attenuation imaging, which we all know, where S1, S2, S3 roughly corresponds to a cap value of 238 to 260, 260 to 290, and 290 to 400. This was a meta-analysis, Wang et al., which gave us these cutoffs. But now we also have these attenuation measurements in ultrasound and in US also. And what we do is we measure the attenuation coefficients. And this is based on the comparison of the amplitude differences of signals given in two different frequencies. So a higher signal frequency will attenuate more as it passes through a fatty liver, and then you compare the slope of attenuation of two frequencies and you can quantify the fat, and this is by ATI, by UGAP, and ATT by Hitachi. What is very interesting is, let me move on, the assessment of portal hypertension. And we can have US guided portal pressure measurement and also two relatively uninvasive modalities, ultrasound contrast transit time and subharmonic aided pressure estimation or SHAPE. So we all know that the normal HVPG is less than 5, which means that the pressure in the portal vein is not more than 5 millimeter mercury more than the pressure in IVC or the hepatic veins. When the HVPG goes more than 6, it is subclinical portal hypertension. When it is more than 10, it is clinically significant portal hypertension. and we can divide our patients of compensated cirrhosis into those with and without clinically significant portal hypertension. Clinically, if any patient has varices, splenomegaly, ascites, he has clinically significant portal hypertension. But 30% of patients, despite having clinically significant portal hypertension, will not have these manifestations, and hence they need to be checked. And why is that? Because if a patient has clinically significant portal hypertension, that is a HVPG more than 10, he has a 30 to 40% chance of decompensating in the next 5 years versus less than 10% if he does not have. So this was the first study by Kenneth Chang et al. In which they used a 25G Cook insight needle and a Cook transducer to do a transgastric transhepatic puncture into the portal vein and then the hepatic vein. The downside was that they did not measure HVPG to correlate, and subsequent studies have also compared the US portal pressure measurement with surrogate measures like varices, fibrosis, but nobody has directly compared it with HVPG. Now this is the difference between portal pressure gradient measurement by transjugular HVPG and US guided portal pressure measurement. When we do a transjugular HVPG, a catheter, 7 French catheter is taken in the hepatic vein, mostly the right hepatic vein, and the free hepatic vein pressure is measured, and then a balloon is inflated and we wedge it into a hepatic vein, and once the flow is occluded, this entire column is one pressure head. So across the sinusoids, you are measuring the portal vein pressure, and the wedged hepatic vein pressure is then taken to be a surrogate of portal vein pressure. However, if you remember the Semtisunam trial and subsequent trial by Acosta, it has been observed that in NASH cirrhosis, the wedged hepatic pressure particularly does not very nicely correlate with portal vein pressure, it underestimates it. So in hepatitis B and C, HVPG works very well. When we are talking of NASH cirrhosis, HVPG actually has a lot of errors. With EUS, you are puncturing the hepatic vein directly, the portal vein directly, and at least in a certain subgroup of patients, this may be more useful or more accurate than HVPG. And this will show you how it is done. This is a video I got from Cook. So you have this 90 centimeter long tube, you have this transducer, you press this button to make it on, you fill in heparinized saline, then you attach it to the transducer, transducer to the tubing, tubing to the end of the this special 25G needle, and then you flush the whole system with heparinized saline. So now the whole system has heparinized saline in it. Then you fit it on the EUS guided, on the EUS scope, like a normal FNA needle. You go inside, and from the proximal stomach, you locate the hepatic vein first, and then you target it. And then after waiting for the pressure to equilibrate for around 30 seconds or so, we take 3 readings. And then we average it. Then a second puncture is made. Into the portal vein, and now we measure the portal pressure once, twice, and then thrice. And now, unlike free minus wedged hepatic pressure, EUS guided portal pressure measurement is just the difference, and in this case it is 7. Let me show you one case. This is how we see and locate the middle hepatic vein. Middle hepatic vein is very big, it comes right under you. We use a Doppler to confirm the middle hepatic vein, and then we puncture it. Since we are puncturing with a 25G needle through a liver parenchyma, bleeding doesn't happen. The parenchyma collapses to tamponade the track. So like this, we puncture the hepatic vein, and then we flush, and then we take the hepatic vein pressure measurement. And this is very simple, And as I have mentioned, in certain situations it may be advantageous. My time is running out, so I shall go forward. So what really excites me is that we can now estimate the hepatic vein pressure gradient, at least CSPH, non-invasively. And we use this very often in the department, the transit time of ultrasound contrast agent. So just bear with me. Once we inject ultrasound contrast agents in the endocubital vein, it goes through the right heart, through the lung, it's a transpulmonary contrast, left heart, aorta, through the celiac artery, hepatic artery, enters the liver through the hepatic artery. Also goes into the splenic artery, superior mesenteric, and then through the portal vein enters the liver, passes through the liver and exits through the hepatic vein. So what is the transit time? Basically two transit times we take. Hepatic vein arrival time, which is the injection from this point to the appearance in the hepatic vein, and intrahepatic transit time, or ITT, which is appearance in the hepatic artery to the hepatic vein. Now you can well imagine that this transit time or duration will be influenced by the transit through the liver. Once cirrhosis develops, you have the shunts in the liver from hepatic artery to vein and portal vein to hepatic artery, and hence the transit time is hastened in the liver. You can also have intrapulmonary shunts, and you can have hyperdynamic circulation. So I show you two studies. These are also by radiology. In Kim, a hepatic vein arrival time less than 14 beautifully correlated with HVPG more than 10. Most of these were compensated cirrhosis. In compensated cirrhosis, it is mostly the intrahepatic events which influence the transit time. In Jeong, the intrahepatic transit time of less than 6 correlates with HVPG of more than 12. So this is a 5 minutes job where you can estimate the hepatic venous pressure gradient by using the ultrasound contrast time. This is how we do it in the department. We focus the hepatic artery first. Unlike the radiologist, we cannot focus the hepatic artery and vein in the same plane. And we calculate the hepatic artery arrival time at 12 seconds. And immediately we rotate counterclockwise and focus the left hepatic vein. And this is the arrival time in hepatic vein of 37 seconds. We can be more accurate by creating the TIC graphs. And the hepatic vein arrival time here is 37 seconds and ITT is 25 seconds. So this is a normal patient. This is something which I find very promising, which will come up, the subharmonic aided pressure gradient. I will not go into the detail because my time is running up. In general, if a vascular chamber has higher pressure, then the subharmonics which come out of it, which are reflected out of it, will have a lower amplitude than a chamber, vascular chamber, which has lower ambient pressure. So if a hepatic vein or a portal vein has higher pressure, the subharmonic amplitude will be proportionately less. So you measure the subharmonics after titration, over the portal vein, over the hepatic vein, subtract, and this gives you beautifully the shape gradient. And this I foresee in next few years will replace most of the HVPG measurements invasive that we do currently. So many more new techniques are coming up. My time is running out. I shall, Dr. Chhagan, just take 1 minute. 2 minutes and go on. So we can also do a lot of hemodynamic and vascular evaluations of all of these vessels in US. I shall just mention the portal vein and hepatic vein. These are the portal vein changes in cirrhosis, which you should know. It basically dilates. The flow can stagnate, flow can go to and fro, or flow can reverse. The peak systolic velocity goes down, the mean velocity goes down. And this is how you see the portal veins in US. This is shown below the baseline because we are measuring in this segment. It has respirophasic variations and some transmitted pulsations. When cirrhosis develops, it becomes more sawtooth, the periodicity increases and it can become to and fro. We can also very nicely see portal vein thrombosis. Because portal vein is right in front of us, we can display it as a very big vessel. We can distinguish a bland thrombus from a tumor thrombus, and we can also use a contrast US to define whether part of it is bland and part of it is tumoral, and we can also needle an FNA and sample inside the portal vein. The hepatic vein waveform on US is routinely checked by us when we are doing liver patients. There are basically antigrade waves and retrograde waves. The only things that the fellows have to remember is, unlike transabdominal ultrasound in US, the spectrum of hepatic vein is flipped, so that the antigrade veins, 1 minute more and I'm done, is above and antigrade is below. And this is a normal hepatic vein spectral on US, and certain changes happen. The hepatic vein becomes narrow, the caliber variations increase, branching becomes wider, and the spectrum becomes biphasic and then monophasic. And if it is monophasic, the HVPG is more than 15, and it correlates also with very much with fibrosis. So non-invasively, we have a lot of surrogate for fibrosis and portal hypertension. And these are just some of the cases. Sometimes we pick up these changes unexpectedly. We can also do US guided endotherapy of varices. This is a whole big topic. These are vascular coils which we have adapted from the interventional radiologies. These are made of inconel and nitinol, and these have radiating nylon fibers called wool coils, and they help to form coagulation. And this is my protocol for US gastric varices endotherapy. We look clinically at these patients. We don't do US in all. We look for portal vein thrombosis. We look for ascites, hydrothorax, and untreated esophageal varices. If any of these are present, we look at hepatic encephalopathy or sarcopenia. If these are present, well, then these patients is not a candidate for BRTO, not a candidate for TIPS. These are the perfect patients for US. If HE and sarcopenia are present and the patient has portal vein thrombosis, ascites, then he is better treated with TIPS and trans-TIPS embolization, because you are treating, besides the varices, the entire patient. If these are not present, then we do a CT scan and look for the applicability of RTO, and if so, they can still be treated by US or BRTO, otherwise with US. So if you are to do studies comparing US and BRTO head to head, this is the only subgroup that you should actually be including, and not all the patients as previous studies have done. I shall skip this. This is a bleeding patient and injected coils, and 5 months down the line, this is how glue and coil extrusion happens. Really useful in treating duodenal ectopic varices, and we have learned to use mini probes also for ectopic varices, and we inject coils, and this is how the coil extrusion happens in duodenal varices. These are straightforward techniques, not much brain, so I am rushing through these. But the point I would make is very few patients, 5 patients here, rectal varices, exceeding the time. This is actually a very big topic. I can't complete most of these.